Hi, good afternoon, everyone. And again, welcome to another episode of Now You Know. This has been ongoing, so this is a special one today, guys. This is a series, Now You Know, is a series of moderated fireside chats presented every second Sunday of the month and is sponsored by the St. Rose's Alumni Association. Each episode showcases a pertinent lifestyle issue presented by a professional in finance, health, wellness, and more. Today, we will hear from Dr. Michelle Matthews, and I am Joy Mosley, your moderator for today's episode. And remember, please use the chat to ask any questions that you may have. And now I'll introduce Dr. Michelle Matthews. Oh, sorry, guys. Technology. Okay, Dr. Michelle Matthews is a physician board certified in internal medicine and pediatrics. She attended Wayne State University of Medicine in Detroit, Michigan, where she received both her Doctor of Medicine and her PhD. She completed her residency in internal medicine and pediatrics at the Detroit Medical Center and the fellowship in addiction medicine also at Detroit Medical Center. During her 30 years of practice in medicine, Dr. Matthews has practiced in multiple care delivery models, including hospital medicine, ambulatory medicine, skilled nursing facilities, specialty care centers, population medicine, and administrative medicine. During her tenure as a physician, Dr. Matthews has served as an expert in geriatric medicine, end-of-life care, and medical ethics. She currently serves as the medical director in the area of population health for a private for-profit organization in the state of North Carolina. And here she is, Dr. Michelle Matthews.
Good afternoon, everyone. Joy, thank you so much for your introduction. I am happy to be here this afternoon to speak of how we navigate healthcare in the end of life or in chronic disease. I'm going to start off with just presenting a case study, and then we'll go from there. So this is a 69-year-old African-American man with a history of prostate cancer. He was diagnosed at age 67, and he lost his fight with prostate cancer at age 69. During the 2 years of his diagnosis, he was hospitalized 14 times and received several different forms of treatment for his prostate cancer. The patient ended up dying in the home with his family around him. And prior to his dying, he was on hospice for approximately 1 week. So I just want us to just sort of chomp on that a little bit, and I'll come back to it. And what I want to talk about is chronic disease. There are multiple definitions of chronic disease, but I like the definition that has been put forth by the World Health Organization. And the World Health Organization speaks of chronic diseases as non-communicable diseases. And that means that a disease that you can't get from being in contact with someone else. And it usually has a long period of onset and lasts, in most cases, throughout the life expectancy of the patient who has it. Most of those chronic diseases fall into 4 categories. The number 1 category is cardiovascular disease, number 2 being cancers, number 3 being pulmonary disease, and the 4th one being diabetes. Now, I'm sure that if you were to think of those 4 categories that I spoke of, you could probably identify someone you know, maybe someone in your family or a friend who has those diseases. So the question becomes, how do we navigate our care in those diseases? There's one very important part of chronic disease that I want to mention. And before I do that, I want to give some definitions. One is what we call the definition of cure in in Western medicine. And cure would be equal to never having had the disease. So when you have a chronic disease, we do not speak about chronic disease in terms of cure. And why is that? That's because once chronic disease has exerted its impact on the organs, even though you may feel better, even though, as people say, my numbers are back to normal or they look good, it doesn't mean that the organ has not had some damage, some irreparable damage to it. So when someone has chronic disease, there is no cure for it. So what that means is that your chronic disease will continue with you through the end of your life.
So this is what is considered a chronic disease that Dr. Matthews just explained, something that stays with you through your entire life.
Yeah, through your entire life. Some people might ask, what can we predict with chronic disease? So what I will say to you, and I'll throw this out there, and this statement may be a bit controversial, and I expect to get reaction to it. But when we have chronic disease, medicine can predict the course of the disease up to and including death from this disease. So am I saying that we can, in medicine, tell when somebody can die from chronic disease? No, we cannot do that. We do not have a crystal ball in medicine that can predict when someone may die with it. But we can predict what the course of the disease will be. We also have very good data that helps us to understand when we see certain things happening in medicine, what does that prognosticate for the future of that patient with the disease? Most of the time when someone has chronic disease, I spoke about those 4 categories: cardiovascular cancers, pulmonary, and diabetes. The 2 disease categories that go together very closely are cardiovascular and diabetes. And I'm going to ask people to use your reactions in the chat. If you know someone who has diabetes, raise your hand. And you have the reaction. You can either raise your hands physically, you'd have to turn your camera on for that, or you can raise your hand in the chat. Okay, I see some people raising their hands. If you know someone who has diabetes, raise your hand. Okay, I see 1, 2, 3. Okay, 4. If you know someone who has both cardiovascular disease and diabetes, and when I say cardiovascular disease, I'm talking about things like have had a heart attack, they have coronary vessel disease, they have congestive heart failure, they may have hypertension, they may have had an amputation because they couldn't get blood flow to their organs, to their legs. If you know someone who's had both diabetes and cardiovascular disease, raise your hand. Okay, so I see all these hands going up. So what this is telling me is that all the people that raise their hands, you're going to be talking about with either thinking about or talking about with the people, if they're hopefully if they're loved ones close to you, as to what does that look for them in 3 months, in 6 months, in a year. So what should you be expecting from your doctor when you have chronic disease? I just told you that you're going to be talking and thinking about what you should expect as you go down the road. And I just told you that we have very good predictors that tell us about what we should expect. So the question becomes, how does that inform how you have a conversation with your doctor. So I'm going to take us back a little bit to when you were a child, or for those of you who have children. When you have children and you go to the doctor tells you, well, you can expect your child to grow this much. They've got growth curves. They've got all of those things that they tell you. When the baby's first born, they'll say to you, your baby should have these many wet diapers in a day, and they'll tell you that their stool can be soup to nuts. In medicine, we call that anticipatory guidance. Basically, your doctor is guiding you on what you should anticipate for the growth of your child. When you have chronic disease, you should, in the discussions with your doctors, ask for the same thing. So your doctor is helping you to treat the disease, but you should also be having discussions on what should you expect with these diseases.
So this is what you call anticipatory guidance. This is what you mean when you go to the doctor and you ask.
Right. That's correct, Joy. What we should be having, we should be talking to our doctors about how do we treat the disease and making joint decisions with that, and also asking for anticipatory guidance. So the first thing I want to talk about is making joint decisions. In medicine, when we think about those 4 categories of disease, there's some things that are absolute. What I mean by that, if you don't treat diabetes on some level, you're going to have organ damage. You're going to end up with complications, and those complications can be significant. The complications can include kidney failure, where you end up on dialysis. So hypertension and diabetes are the leading causes for dialysis in the Western world. Diabetes is the #1 cause, or is the #1 associated disease for people who end up with amputations. So it is absolutely necessary to treat those diseases on some level. When I talk about joint management, you as a part of the decision-making team with your doctor, there's some other things that really you need to talk to your doctor about. So for instance, if you have high cholesterol, it is not absolutely necessary that you get on a medication for it. It depends on risk factors. It depends on family history. Depends on a number of things. So you're the expert on your family history. The doctor's not. So you become a contributor in that process, and you should be talking with your doctor, because there are also adverse effects to medications. And so you want to talk to your doctor about weighing the adverse effects versus the benefit of that. So I think the takeaway point here is that when you are talking about chronic conditions, chronic disease, you should expect treatment for the disease, and that sometimes is a sort of a directive from your doctor on what your options are. And a part of that is you being a joint co-decision maker in the treatment of that disease. And the other thing is you should expect anticipatory guidance, what to expect when you have this disorder. I'm going to stop there to see if we have any questions in the chat about that.
I don't see any questions in the chat. So to summarize what Dr. Matthews is saying, so if you do have a chronic condition, not only should you receive treatment for the condition, but you should also have some level of discussion with that provider or physician who is taking care of you. So you have to be that joint person there with the doctor, because it's your body that needs that, I guess, treatment. Okay, so and you need to know what to expect for the course of action for that condition.
Thank you, Joy. The other thing I would say about that, if you have questions, write them down. so that when you go in to speak with your physician or provider, you don't forget them, because invariably when you're in the home, when you're in the office, you're going to forget some of those questions. And then when you get home, you say, I should have asked that question. Or when you're walking out, when the doctor is walking out the door, you say, oh, I've got one more question. And by that, I will tell you that at that point, the doctor is probably having to move on to someone else. And so it is likely that your question is not going to be answered at that time. So please write it down so that you can ask when you're going in.
Well, thank you so much for that reminder, Dr. Matthews. Thank you.
Yeah. So I want to move on to a second part of my discussion, because I did mention it. I said that we have ways in which we can predict the course of a disease. I'll give you an example. If someone has congestive heart failure and they've had to be hospitalized for what we call an exacerbation of that congestive heart failure, and if you're not able to identify a precipitating cause, so let's see what I mean by that. So the holidays are coming up, and a lot of people are eating, very tasty foods, but many of those tasty foods have a lot of salt in them. So they may eat salt and then they end up in the hospital with a flare-up of their congestive heart failure because they're retaining fluid. So that's a precipitating factor. But let's say, for instance, you can't identify that you've ate something badly or you stopped taking your water pills or diuretics, and you end up in the hospital for an exacerbation of your congestive heart failure. We can predict that your mortality risk, meaning your risk of dying over the next 12 months, is about 80%. So what that means is that if you had 100 people, if 100 people ended up in the hospital because of a flare-up of their congestive heart failure without an identifiable precipitating factor, it is likely that 80 out of that 100 people will end up dying within the next 12 months. And I know that for many people hearing that, they're probably taking a breath, because nobody really talks about those statistics when you go into the doctor's office. But we have very strong data that tells us that, and it's reproducible data that has shown that. Now, why am I discussing a precipitating factor? And the reason that we talk about the difference between people who have a precipitating factor and those that don't is that if we have a precipitating factor, then it is very likely that we're able to implement measures that can prevent you from having that precipitating factor occurring again. So if you ate something that had a lot of salt in it, you ended up in the hospital, we can modify your diet as long as you are willing to adhere to that. You can modify the diet so that does not become the driver for you ended up in the hospital. However, if you do not have an identifiable precipitating factor, then there's nothing to modify. And so this can happen again without us being able to implement anything. And when I say us, I mean the doctor and the patient together, being able to implement something that can prevent you from having that happen again. Same thing with diabetes. Your diabetes gets out of control and you end up hospitalized with very high blood sugars, or what we call ketoacidosis, which is where your blood becomes acid because of the amount of sugar that is broken down in the blood. If you have a precipitating factor, so one of the things that happens is that sometimes elderly people get into, or people who are on Medicare, they get into something that's called the donut hole. And the donut hole means that they've exhausted their benefits to pay for their medications, and they have to, we say you have to rack up a cost of medications to a certain amount again before what we call the catastrophic benefit will kick in. So there's a period of time for which people are not able to afford that medication. If you end up in the donut hole and you end up with your blood sugars out of control, then we know that we can do something. So it may be a social worker getting involved, helping you to find alternative sources for getting your medications. So those are the things that we're talking about. Now, if you're getting into that, somebody has to speak up. And that's where I would say call your insurance company and talk to them about it. They have case managers there that may be able to assist you with that. When you go to your doctor's office, many physicians' offices, if you have Medicare, are required to have case management that can help you with that. So let them know at the doctor's office if you're getting to that point, because that one complication of not having the medicine can get you into a point where you may not be able to come back from that. You may have a complication such that it leaves you with loss of limb, if not loss of life. So the takeaway points is that we can predict disease. We can predict course of disease. If you get into some situation where you're not able to access your health care or access your medications, I would say speak up. Call your insurance company to see if they have any areas to help. Let your doctor's office know, because they may have alternative places. Get online. If you have somebody who can go online for you to help you to see whether or not there may be pharmacy assistance programs through the pharmaceutical companies. If you go to a senior center, talk to people at the senior center, because oftentimes they have information that is coming through to them where they can give you some assistance. Okay. I'm going to stop there to see if anybody has any questions. Okay. So when we are predicting what happens, the question that many people might ask is, so can you predict when somebody's going to die with this disease? Or do we, how do you know? You're not God. How do you know that somebody is going to die? And how do you know when they're going to die? Well, like I said before, I don't know when they're going to die, but I can pretty much give you a good ballpark of the fact that we expect them to die from a disease within a certain time period. And we do that, we have tools that we can use to help evaluate that. And some of the things that tell us about whether somebody is having debilitation because of this chronic disease is unintended weight loss. That's a big one. So if a patient is having unintended weight loss, that should be a red flag. And the people who are maybe most qualified to speak to that are the people who are seeing the patients every day. Okay. A scale is a really important tool that you can have in your home for a number of reasons. So it doesn't matter. We talk about those 4 categories of chronic diseases that have the greatest mortality risk, meaning the risk of complication, and morbidity risk, which is the risk of dying. Those 4 categories: cardiovascular, cancers, pulmonary, and diabetes. Weight loss or anorexia, with all of them, are very significant negative predictors. And many times we say, well, the patient's losing weight because they're not eating. How many of you have tried to lose weight? How many of you have been on fasting, intermittent fasting? Anybody? Raise your hand if you have. And then I want you to keep your hand raised if you have lost significant weight by fasting for even 4 days. Oh, there we go. So if we just think about ourselves, if you fast or you withhold food, it takes a really long time before you start seeing weight loss. But if you think of someone with chronic disease, they start losing weight progressively, and they are eating. They may not be eating as much, but they're still eating. So that should tell us something right away. That should tell us that there's something going on with the metabolism within the body that is actually causing them to lose weight. And that thing is the disease. It's the disease. So if I were to break it down to you, for cardiovascular conditions, what is the mechanism? The cells are not getting enough oxygen so that they can actually metabolize the nutrients and uptake it into the body. So that food is just passing right through them without them being able to absorb the nutrients. In cancers, you have an overgrowth of the bad cells so that the good cells are not making up the bulk of the muscle, or what we call the interstitium, because the bad cells are overgrowing. When you think of pulmonary disease, usually when somebody's losing weight with pulmonary disease, that's because even though they're breathing in, they're not getting enough oxygen that's getting into the blood from the lungs to keep the cells vital within the body. So they're losing weight because just about every process in the body requires oxygen. And then we think about diabetes and they're losing weight. Most people who have diabetes, they have central weight gain, they're overweight, they have what we call a metabolic syndrome. So if they're losing weight in diabetes and they're not a type 1 diabetic, that's telling you that the vessel disease that they have developed is such that they're not getting oxygen or good blood flow to the organs. And so weight loss becomes a big, big, big thing. So that's one thing. Number two, if someone is having to keep going back to the hospital or the emergency room, what that says is that the management of their disease is out of control. Because chronic disease is not managed in a doctor's office. Pam, I'll get to your question in a moment. I just saw it. Chronic disease is not managed in a doctor's office. A chronic disease is managed in the home. The doctor adjusts treatment for the chronic disease, but the chronic disease is managed by that patient within the home. So what do I mean by that? If you have diabetes, the control of your diabetes is going to depend on you taking your medication. It depends on what you're eating. It depends on your exercise levels. It depends on whether or not you are controlling your weight. Okay? And that doesn't happen in the doctor's office. That happens at home. Every hour of the day, every day of the week, every week of the month, and every month of the year. That happens at home. If you think about cardiovascular disease, the same thing. You're taking your medications, you are controlling your risk factors, which may be cholesterol, your blood pressure, those types of things. That doesn't happen when you go into the doctor's office. That happens at home. If we think of cancers, you might get a treatment for cancer, but the growth of that cell happens every day, and it's not in the doctor's office. And we know that and each cancer is different, so I don't have the time to go into each one of them, but they're environmental and risk factors that actually contribute to cancer formation. For instance, alcohol. That's a big one. Alcohol and smoking, those are two environmental factors that actually impact a cancer. And who controls that? Certainly not the doctor's office. The patient in the home controls that. And so if we think of it, chronic disease is not managed in the doctor's office. Chronic disease is managed in home by the patient and their family and whoever the stakeholders and caregivers are. Pam, I see a question. Is it normal for someone to lose his or her appetite when not fasting or on a diet? That's a great question. No, it is. It is not normal for you to lose your appetite. So when someone is fasting, they may have what we call a rhythm, a circadian rhythm that's developed. But so for instance, if you're fasting for, let's say, 4 hours in a day, your body may become accustomed to expecting food at a certain time. And so you don't start having hunger until you get to that point. What you may have in your fasting is your body may require smaller amounts of food before that hunger is satisfied. Okay, because when you're fasting, your stomach may shrink, so it requires less food in order for you to have those stress receptors work and tell your brain that you've gotten food. However, if you are fasting, you're going to get hungry. Now, some people will suppress that hunger. Many people do praying and fasting, and what they'll do is that they will pray through that so that they are not responding to the hunger. But they don't forget to eat. For someone who is in the advanced stages of their disease, and Pam, if I were to wager a guess, I am going to say that one of the things you are considering when you ask this is maybe dementia. Because as you get, so let's talk about chronic disease. As your body is doing less, and you're requiring less energy, you're going to require less food to give you that energy. And that often happens when body systems are starting to shut down. Does that answer your question? You can
Yes.
type it in
Yes, it
the
does.
chat.
Yes.
Okay.
Thank
All
you.
right. Now, I want to talk a little bit about dementia. And because that's a specific chronic disease that's not really considered in that top 4, but it is starting to emerge as one of the more common causes of chronic disease. And one of the reasons that we don't categorize it by itself is that we know that for dementia, the same risk factors that we have for cardiovascular disease and diabetes are the same risk factors that we have for dementia. And dementia is to some extent hereditary. So we don't have all the data for dementia, but we know the associations with it. And dementia is a sort of a separate category on its own, meaning that you actually have physical derangement of body functions. For instance, people may have problems with swallowing so that the food goes down the wrong way. Instead of going into the esophagus and into the gut, it might go into what we call the windpipe or the trachea, and it gets into the lungs. And that creates a whole separate set of problems for patients. So in summary, I would say we have predictors and we need to understand what they are. So what should you be asking your doctors? Can you, if you have a loved one who's been in the hospital several times, what do you think about their life expectancy? What should we expect as they're going along with this? So the next part I want to go on to is there's an ecosystem of healthcare. And I think that what I'd like to do is help people to understand what that ecosystem is. So I often say the ecosystem starts with conception and ends with death. So with conception, you start off with an OBGYN, right? That's the person who's getting you through the pregnancy. And then you have a pediatrician, and you may have a pediatrician or a family medicine doctor. And then when you grow up to be big people, you may have a family medicine doctor or an internist. And then as you get older, you may have a geriatrician or an internist or a family medicine doctor. And then when medicine is no longer able to impact the course of the disease positively, you may have a doctor who just takes care of managing symptoms, and that's a palliative care specialist or a hospice physician. So I've talked a little bit about what you should be talking to your doctors about as adults and as you get older. I think one of the things that's important is to understand what is normal aging, and that was a question that was just put in there. What is normal aging and what is what we call pathological aging? So macular degeneration, people have heard that, age-related macular degeneration. The name says it. It is age-related, and that's where you can lose vision in your eyes. Okay, so that's an age-related, but it's also pathological because everyone who ages does not get macular degeneration. And if you have something we call wet macular degeneration, that is certainly a pathological condition, but it doesn't, it happens as you age. So that is both age-related and it is pathological. Hearing, loss of hearing. As we age, everyone will have some loss of hearing. That's age-related. Now, there's also hearing loss that can be pathological. You might have a loss of the function of the nerve that causes you to hear, or you might have and some type of injury. And so you can have something that is because of some type of pathology or disease, but for everyone, we're going to lose some parts of the spectrum of sound as we get older. So that's normal aging. Osteoarthritis is a wear and tear disease. So if you get old enough, you will get osteoarthritis just because of how we stand on our bodies. Okay. Now, not everyone will get it, but for most people who live long enough, because of how we are erected in our bodies, if you think of most animals, they are on their hands and knees and they're offloaded their spine, right? So I say hands and feet, thinking of the front paws of the hands and the back paws as their feet. So most of them, their spines are offloaded. Any other animal you think of, monkeys, they go between being in the upright position and being in the horizontal position where their spines are offloaded. Humans are the only one who exists in a lifetime where we are loading our spines all the time. So we're going to have some wear and tear on there. And that you might hear arthritis of the spine, degenerative joint disease, degenerative disc disease. That's because our spines are loaded all the time. And that's why things like yoga and stretching or inversion, people talk about inversion therapy. All of that is considered to be really good for the spine because at that point you're offloading the spine. Okay. Now that's not to say that you need to just lay in bed, for extended periods of time. But so some things are normal aging and some things are pathology, and it's important to have an understanding of that. So ask your doctors about that. Ask your doctors about, is this normal or is this because of disease? But understanding the ecosystem, I think as we get older, we really need to become very familiar with geriatric doctors who can take care of disease, but also hospice and palliative care. Has anybody had any experience with hospice or palliative care? If you have, raise your hand. Family member, friend, anyone? Okay, I see one hand raised. I see two hands. Desiree, can you unmute Nadine for me? I just want to ask you to share your experience with what your experience was with hospice or palliative care.
In my situation, Fortunately or unfortunately, it was not very long because it was my mom and she was briefly in the hospital. And then by the time they sent her to a hospice, she pretty much died, within a day. So we didn't have long with that.
Okay. Thank you. Thank you for sharing that. So you are moving me right into into the next segment. And you said, fortunately or unfortunately, she only had, and I'm listening to those words because those are very impactful words in the story. And for those of us, most people, when they hear hospice, they think death. And I will challenge you to say hospice is not about death. Hospice is about life. And hospice is really about how do you live with a disease when medicine can no longer effectively treat that disease. So I want to go back to the story that I started with at the very beginning. The 69-year-old man who had prostate cancer, who was frequently hospitalized and eventually lost his battle with cancer. That story is very personal because that's the story of my father. My father had a chronic condition. His chronic condition was prostate cancer. And my father kept going back into the hospital for complications of his cancer. I will tell you that my father was not a little man, and he started with losing weight. And when my father started losing weight, people were excited because they said, oh, he stopped eating fried food and now he's losing weight. I will tell you that I knew immediately that this was not because of a diet. And I knew that because my father had been trying to lose weight for years and it had not happened. I also knew that my father had been diagnosed with prostate cancer and had received treatment for it. But there was a good chance that he now had an extension or an advancing of that disease. And his doctor never discussed that as an option for him until my father fell down in the driveway and had to be taken to the hospital. And he was found to have a platelet count of 20,000 when the normal was 150,000. And that was very telling because what that told me is that his bone marrow was no longer working to produce platelets. And that's because it had spread from his prostate into the bones and it was taking over the bone marrow so that the bone marrow could not do its usual work. My father got initial treatment, which improved his condition, but prostate cancer is a chronic condition. Most people will die with prostate cancer than from prostate cancer. My father did not have diabetes. He did not have cardiovascular disease. He did not have pulmonary disease, but he did have a chronic condition. And for the next 2 years of his survival, he spent most of that time in the hospital. I spoke to my father and I asked him, what do you want? And his answer was, I want to live. That's the answer that you're probably going to get from most people. But because I'm a physician and because I understand what can happen as disease advances, I actually had a conversation with my father. And I asked him, would you want a feeding tube to keep you getting food if your disease is making you sick? And he said he did not want that. I asked my father, would you want to continue treatment if the treatment is making you sick and causing you to come back to the hospital frequently? My father said, I didn't want that. He said, I want to be home with my family. So I had these discussions with my dad. As his disease advanced, he also ended up with a stroke because of the spread of the prostate cancer. And even at that point, most of my family felt what they found other reasons for why this was happening. And the other reasons were, it's the medication, it's because he's in the hospital. But I recognized that my father had had a stroke. And everybody wanted more treatment because as human nature, we don't want to let go of our loved ones. And so it is really, really important that as a part of navigating chronic disease, we have conversations with our loved ones before they get to that point about what would be good for them. And it's not about how you want to die. That will come up at some point. But it's really, how do you want to live? Do you want to spend more time going to the hospital, or do you want to be at home with your family? Do you want to be able to continue eating the things that bring joy to you, even though it might cause you to have some complications, or don't you? And those conversations, when you have them, it's important to write them down. And those things are called advance directives. So does anyone on the call have an advance directive? So I only see Nadine, Claire, and my hands raised. And I will tell you that I have I see Joy also.
Just want to say, ask, you said an advance directive. Now, I have a living will. Is that the same as an advance directive?
Okay, very good question. So a living will is a form of an advance directive. So maybe I should ask that question again. Does anybody who has a living will? Let's see if we get more hands. Okay. All righty. So thanks for bringing that question up, Joy. So an advance directive is you saying, I am saying in advance, I am directing what my care should be in advance of how I want it to be. So that when decisions are made, it is not the decision of the person who is telling the medical profession or the medical organization. It is actually you that's telling them. It's not the person who is standing in as a surrogate. You're the one that's speaking for yourself through an advance directive. Now, you might say, well, how do I know what's going to happen at that time? How can I say what I want? We're talking about chronic disease, and we can predict what chronic disease will do and how you'll end up living with chronic disease. Okay, can you guys hear me?
Yes.
Okay, I'm frozen on my end, so all right, good. So it is not about what's happening in that moment. So let me give you an example. We have someone who has congestive heart failure. Let me use COPD. That's a better one because people may better be able to visualize that. COPD or emphysema. Okay, you've got someone who's got emphysema. Let's say they're on oxygen. They've been on a ventilator several times. They continue to smoke. They have difficulty breathing. They may be on a home ventilator at night. Okay. If that person gets to a point where their condition is deteriorating, they can tell you whether they want to be on a ventilator, whether they want feeding tubes, whether they want to go back to the hospital. Again, because what they're really telling you is, what quality of life do I want in the setting of all of this? So the doctor is going to tell you how they can recover from it. What you need to get from them is, what do you want your quality of life to be like? Because whether I am able to sleep in my bed at night or if I'm sleeping in a hospital bed, that's about quality of life. And the patient is the person who is best equipped to speak about that information. Somebody can say to you, I really enjoy putting that food in my mouth and chewing it and swallowing it and tasting it. I want to be able to do that. And if you say to them, well, but if you do that, some of that food might go into your lungs. They can say to you, you know what? I'm willing to take the risk of that happening. And I know that if that happens, I can't fix the underlying problem, but I want to eat and taste my food. So what we know is that if that person, if that's what they value more than preventing the food from going there, then that's what we call goal concordant care. Just one moment, please. That's what we call goal concordant care, meaning that the goals of the care are in concordance with what the patient values in their life. So those are the conversations that, as you with chronic disease, you should be having with your doctor, your provider, whoever it is. But what does goal concordant care look like for me? Nadine shared that her mom was only on hospice for about a day, and then she lost her battle. So I will tell you that all the data that we have, every bit of the data shows that for patients who have chronic disease, where there's no effective cure or effective treatment for their conditions, patients who are on hospice for more than 30 days have the best quality of life and dignity with death. Okay? We have terms that we use in medicine. For instance, patients on dialysis, we say we don't want to crash start them. And what that means is that we want to be able to talk to them about their kidney disease as it is occurring and prepare them for what's going to come. So we plan for putting a graft into their arms. We plan for starting dialysis. Versus the patient that we have to crash start, meaning that the patient's been having bad kidney disease and nobody's talked about it. And then they show up in the hospital in full renal failure and we can't do anything about it. And we have to get them on dialysis today or they're going to die. And then we have to put in things that give them a greater risk of infection. And then they've got to come back after they've started dialysis where they're just not healthy enough. And then we've got to try to get that graft in. Right? So that's crash starting them, and that's not a good way to do this. That's the same thing with death. Death and dying with chronic disease. It is much better for us to not have to crash treat somebody at the end of life where we can plan for it. So I can't speak enough about the importance of advance directives, making sure that you talk to someone, put it on paper, get it notarized, make sure your doctor has a copy, make sure someone who you trust to make decisions for you has a copy, and make sure that you're addressing all the things that you want to address in those advanced directives. Go ahead, Joy, you're getting ready to say something?
Yes, we spoke of the Living Will Advanced Directive. Healthcare proxy, how does that fit into this?
Okay, good question. And I'm watching our time.
Yes.
So a healthcare proxy is someone who will, as a surrogate, who will make decisions for you when you're not able to speak for yourself. Some people know it as the healthcare power of attorney. Some people know it as the proxy. In some states, you can have a proxy without having an advance directive. In some states, they're together and they're not separated. You've got to know what is the correct thing in your state. Most of you are in New York, and I know that in New York, those are two separate documents, a healthcare proxy and an advance directive. So the healthcare proxy is someone who will speak for you when you're not able to speak for yourself. If you do not designate someone, then we have what is called a hierarchy of surrogate, meaning that if you're married, then it's your spouse. If you are not married, then it becomes your parents and your children, and it has to be a majority of those people that makes a decision, and those are called next of kin, right? And if you don't have any of that and you do not have a healthcare power of attorney, then the physician at the time makes the decision. And if you have guardianship, then the state will make that decision for you. So that's the hierarchy of it. Before we jump off, the one thing I want to talk about is that there's a simple form. It's called a most form or a post form. It's the medical orders for out of hospital treatment. And you can fill that out and have it, your doctor sign it, and just have you and your doctor sign it and have it there so that people know right up front what your wishes are and you can have them done. Yes, and I see in Florida it says it's 2 separate documents. Thanks, Pam. And I think that is all I have, and I'm going to stop there.
So everyone, I know this has been a lot of information, but it's very good information. I mean, we go about our lives not thinking about this stuff, but we've got to really think, work along, as doctor said, we have to work along with the doctor because we have to be our own advocate for ourselves. And if we have family members as well. So thank you so much for the information, Dr. Matthews. I definitely will be looking into advanced directive and getting my things in order. And I hope each and every one of you on this forum today, if you don't already have these things in place, start to think about these things. And if you do have any of those chronic conditions that Dr. Matthews mentioned, remember, you have to work along with your doctor, but you have to be the person, that persistent person that is going to work from home, like she said. You're at home, you with your diet, changing certain things. If you're into alcohol, all these things, your diet, you have to want to change these things. So I hope everybody was well informed, and thank you again for joining us. And now you know, and hope to see you next month. Thank you all so very much. Thanks again.
Joe, you said the meeting is held every second
Sorry,
Sunday.
every second Saturday of the month. Sorry.
Thank you.
I'm getting excited because I'm yes.
Thank you very much.